Hi, my name is Mark Shrime. I'm the International Chief Medical Officer with Mercy Ships. We've created a new program strategy for the next few years to direct what the ships are doing as we move forward out of COVID. Over the course of the history of Mercy Ships, we started as a primarily surgical delivery organization, doing lots and lots of surgeries in the countries that we partner with. And then gradually over the last decade or so, we've started to build a medical capacity building and training pillar to part of our platform.
Over time, countries began asking for training and opportunities to work together with the teams on the ship. We wanted to create a lasting impact through supporting the health systems in our partner countries to address the long-term needs beyond the time that the ship is in country. Our new international program strategy is moving further in this direction.
As we shift into this next season of Mercy Ships, we really are going to be digging into creating long-term impact, both in the direct medical services that we offer and also in the education, the training, and the advocacy.
Many of the countries that we partner with have very few specialists within the surgical ecosystem. We know that to truly address that barrier to accessing safe, timely, and affordable surgery, there needs to be the people to provide it. Shifting our focus to formal education and training programs, partnering with universities and postgraduate training programs, and longer-term engagement allows us to work towards the outcome of increasing the number of specialist providers across the surgical ecosystem. Education, Training, and Advocacy, or ETA, is working closely together with Direct Medical Services, the hospital, to optimize our hospital ships as training platforms for residency and fellowship opportunities.
With this education, training, and advocacy pillar, we want to move our organization towards longer and longer lasting impact, towards a partnership with the countries, an accompaniment with the countries that host us, an accompaniment of their health systems as their health systems develop. How do we move from optimizing for volume to optimizing for impact? And specifically, how do we measure impact? If you think about what happens to a patient who has a surgical disease, and especially a surgical disease that is ostracizing, whether it's a cleft lip or a big tumor or an obstetric fistula or bowed legs, these surgical conditions have an effect on all sorts of aspects of a patient's life. They have an effect on their health, obviously. If you've got a tumor growing off the side of your face, then your health is diminished. They also have an effect, as I alluded to, on an engagement with the community, on the engagement with the family, being able to get married, for example, on an ability to be an economically viable member of society, and fundamentally, the distribution of surgical disease and access to surgical care is a question of inequity. The vast majority of untreated surgical disease is in the countries in which we work. As we move forward to optimizing for impact on the patient side, on the direct medical services side, these are the sorts of measures, the sorts of metrics that we are going to be using to measure impact. I'll give you one way that we can measure the health effect that we have with our surgeries. Think about what a disease does to people. Diseases do two things to us. One, premature mortality. They can kill us early, so we lose years of life to premature mortality. But also, even if a disease doesn't kill somebody early, say you have a cleft lip or a tumor on the side of your face, you're living your life with a little bit of a decrement, a little bit of a decrease from perfect health. So over the course of your life, the disease is robbing from you years of perfect health. So when we do surgery, we restore to patients not just the years lost to potential premature mortality, but the years of healthy life that they would have lost with their disease. In the public health world, this is called a disability-adjusted life year, but what we're really doing here is measuring the number of years of healthy life that we restore to patients when we do their surgery. On the education, training, and advocacy side, it's similar. In addition to counting the number of hours of training that we do and the number of participants that we train, what is the outcome of that training? What changes in their practice? What changes in the health system and the workforce itself? And again, are we able to reach the most marginalized healthcare providers as we do that?
We are developing outcome measures, determining how to collect the necessary data, and ensuring that as we plan and develop programs, that they work towards and contribute to our overall desired outcomes of increasing the number of surgical specialist providers, creating a network of encouraged and empowered providers, and reaching the marginalized healthcare worker. We are excited about this new direction and continue to pray for wisdom in our partnering, planning, and implementation.